Okay, this is Selected Mental Health Disorders, Nursing 203. Our main ideas that are going to be covered are lifespan issues, personality disorders, and various topics of victimization. We will talk about the abused adults, child abuse, and rape. We're going to discuss some of the childhood disorders. These are the disorders that are diagnosed usually in childhood or adolescence, such as attention deficit disorders, conduct disorders, oppositional defiance, and impulse control. Eating disorders, behavioral aspects of mental retardation. We will not talk a lot about mental retardation. Your personality disorders tend to fall into three main categories. They are odd eccentric, dramatic emotional erratic, and anxious fearful. The behavioral aspects of mental retardations, deficits in general, intellectual, and adaptive functioning. Some predisposing factors to this are your hereditary factors. Hereditary factors are those such as errors of metabolism. Were referenced in your book by the Tay-Sachs disease. Also included in hereditary factors would be chromosomal disorders such as Down syndrome, early alterations in embryonic development. There are various pregnancy and prenatal factors that can cause mental retardation, general medical conditions, as well as environmental and other mental disorders. This is the percentage of each that you see. 5% are hereditary, including inborn errors of metabolism. I won't read through those, but you'll see that your largest category, 30%, are embryonic, such as toxicity, ingestion by the mother of alcohol or drugs, a maternal infection during the development, and those complications that result from that are your largest percentage, followed by 15 to 20% of developmental retardation is from deprivation, which is completely preventable. Maternal illnesses and infections would include rubella, cytomegalovirus, complications, as I mentioned, such as toxemia. Also, uncontrolled diabetes can result in congenital mental retardation. Some examples of problems during the birth process would include trauma to the head that might be incurred during the process of birth, placenta previa, and prolapse of the umbilical cord. General medical condition, these would be problems that would include things like meningitis, encephalitis, poisonings, certain medications, lead ingestion, as well as head trauma. What is notable about your general medical conditions that cause mental retardation or maternal retardation would be that these are not congenital. These are acquired. Also, there are environmental influences of deprivation. As I mentioned, 15 to 20% of your mental retardation is from deprivation. This is from depriving a child of nurturing, depriving this social interaction between a child and caregiver, results from the baby not being talked to. This decreases their ability to learn, to even learn things such as language. It causes a general lack of overall stimulation, and it can lead to severe mental disorders such as autistic disorder. ADD, ADHD, or combined types of this. Chapter 23 in your psych book is it gives a developmental theory And developmental theory is a key to understanding infant, child, and adolescent disorders. ADD and ADHD is going to cover inattention, impulsivity, hyperactivity, and the problems that are associated with that type of behavior. This behavior will occur in 2 or more settings, being that home, work, school, play, etc. It is a deviation from developmental norms, and it is very important in your assessment tool and screening to understand the development that is normal as a child. You will also need to obtain a medical workup, family history, support systems, family systems assessment. If you can identify and treat early enough, it can prevent a lot of these childhood disorders, such as ADD and ADHD, from becoming something that is diagnosable in an adult. For ADD and ADHD, it is typically characterized by those listed on the slide: the inattention, impulsivity, and or hyperactivity. And this is usually diagnosed prior to the age of 7. Medications used for ADD, ADHD are central nervous system stimulants. This is the most commonly used classification of medications to treat this behavior. Now, the actual way that stimulants improve these signs and symptoms is unknown. It is not used to control behavior, but it is used to improve the symptoms that cause the behavior. Now, in most individuals, stimulants are going to produce central nervous system stimulation, things such as excitability, restlessness. However, in a child with ADD or ADHD, the central nervous system stimulant medications produce increased attention span. It controls hyperactive behaviors. It helps improve their ability to learn. However, the CNS stimulants does have a potential for physical dependence to occur. Now, Ritalin is listed on the slide, Dexedrine, Adderall. There are some others. Strattera is one that came on the market in 2002. It is approved by the Food and Drug Administration, specific to the treatment of ADHD. It is a select norepinephrine reuptake inhibitor. The exact mechanism of action, again, how it treats these symptoms, is unknown. Antidepressants are also used to treat ADHD. The most common antidepressants used are Wellbutrin, Pamelor, and Tofranil. It's notable that Wellbutrin should not be given to any individual that has a history of seizures or that is experiencing an eating disorder. Antidepressants in general need to be administered immediately before or with meals to decrease appetite suppression and weight loss. Also, to decrease side effects of insomnia, it is generally better to administer the antidepressants at least 6 hours before bedtime. As with all antidepressants, other side effects that are common would be mood lability, unmasking of latent tics, or involuntary motor movements. Conduct disorder. Conduct disorders, the signs and symptoms are going to range from an oppositional defiance to moderate or even severe conduct disturbances. There is childhood and adolescent onset types, and there are unspecified onsets. Conduct disorders are defined as disturbances of conduct that is severe enough to cause significant impairment in social, occupational, or academic functioning. You can read over the diagnostic criteria for conduct disorder in your book. Basically, a repetitive and persistent pattern of behaviors in which the basic rights of others or major age-appropriate societal norms and rules are violated. A childhood onset requires an onset of at least one criteria characteristic of conduct disorder to be present prior to the age of 10. It is seen more frequently in boys. Behaviors displayed are physical aggression and a poor peer relationship ability. They may have had oppositional defiance during early childhood, and usually this client is going to meet the full criteria for conduct disorder by puberty. And when it is diagnosed prior to the age of 10, these individuals are much more likely to develop an antisocial personality disorder as an adult. However, if the problems occur or have an adolescent onset type, they tend to have the ability to have a more normal peer relationship than those with the childhood onset. They are a little bit less likely to have persistent conduct disorder, and they're a little more less likely to develop antisocial personality disorders than those with the childhood onset type. Many of your teen runaways, repeated runaways, will fit this type of disorder, and it is the most frequently diagnosed psychiatric disorder in childhood. That is conduct disorder. We do see it more in males than females. However, it should be stated that that trend is changing. We are beginning to see conduct disorder being diagnosed more frequently in females as well as males. What we're talking about is a repeated pattern of these kinds of behaviors. Aggression to people, aggression to animals. Now, remember, as I talk about these symptoms, that for childhood onset, these are children before they ever turn 10 years old that are experiencing this highly aggressive behavior to people and animals. The destruction of property, setting fires, deceitfulness, theft of property. These are serious violation of rules. And what you'll see is that they will lack any guilt or remorse for any of their behaviors. Even the cruelty to animals, they will lack remorse for. These behaviors certainly will cause significant impairment in their social, academic, or occupational functioning areas. Limit setting on behaviors is essential. It is imperative that the child feel that the staff, if they require inpatient hospitalization, or that the parents or caregivers, if they are in an outpatient setting, are in control. The parents have to be in control and consistent with the limit setting. Also, keep in mind, remembering that this childhood disorder before the age of 10 very likely can lead to antisocial personality disorder in an adult. Oppositional defiant disorder. This involves behaviors that are generally directed toward authority figures, especially parents, also sometimes teachers or police. Typically, oppositional defiant disorder symptoms begin before 8 years of age. Usually, oppositional defiant disorder is not seen any later than early adolescence, but more commonly, as I said, before the age of 8. It also will interfere with social, academic, or other areas of functioning. It's more frequently seen in boys than it is in girls before puberty, but it's interesting that it is more equalized between boys and girls after puberty. The common behaviors seen with oppositional defiant disorder are stubbornness, procrastination, blatant disobedience, carelessness, negativism, an unwillingness to compromise, and limit testing. The treatment will include family therapy as well as anger management techniques, coping skills, ways to express themselves in a more positive and healthy manner. The diagnostic criteria for oppositional defiance is in your book. You do need to read over that. Basically, the treatment for oppositional defiant disorder is going to be individualized. It's going to be designed to meet the needs of the individual child. Paraphilias. This is an uncomfortable topic for almost anybody. The definition, so to speak, if you could have a definition for a set of disorders such as paraphilias, it would be sexual disorders that specifies sexual fantasies or behaviors that are recurrent and last over a period of at least 6 months. They cause the individual clinically significant distress and impairment in other areas of their functioning, such as social and occupational areas. It needs to be said that very few of your paraphiliacs are going to seek treatment for their behaviors, simply because their behaviors do not distress them. They are not distressed by carrying out their behaviors. As a matter of fact, carrying out their thoughts and wishes for these sexual fantasies or behaviors are actually a way of positive reward because it brings the paraphiliac pleasure. If they are seen in treatment, it is usually from pressure that is placed on them from loved ones, maybe their partner, or maybe they've gotten caught and they're there as a term of jail or law enforcement, or maybe it's a court decision that has put them in treatment. 45% of all people who do suffer from paraphilia who do seek treatment are your pedophiles. And we'll talk a little bit more about each one individually. But 25% of people with paraphilias who are in treatment are exhibitionists, and it's pretty much because they've been caught and it's a court decision. 12% of your people with paraphilias who are in treatment are voyeurism, and again, it's usually because they've been caught. Most paraphiliacs are males. They're males that had established this type of behavior in adolescence. The behaviors peak between ages 15 and 25, but then they do tend to decline somewhat after 25. And to make things more complicated in diagnosing and treating, some individuals will experience multiple types of paraphilias. The public acts of paraphilia after the age of 50 has a very low occurrence. It does still happen in isolation or sometimes even with cooperative partners after the age of 50, but not generally as a rule. The types of paraphilias. You have your exhibitionism, fetishism, frauderism, pedophilia, sexual masochism, sexual sadism, and voyeurism. Remembering again, as I read out those types, that 45% who are in treatment are there because they're pedophiles, 25% exhibitionist, and 12% are voyeurisms. Now, exhibitionism is the recurrent urge to, or the act of, exposing one's genitals to unsuspecting and non-consenting persons. Sometimes during this exposure, masturbation may occur. Whenever this individual has any free time or time that they're left to think about their behaviors. Their stress increases. So whenever they're allowed free time by themselves, the incident that they're going to expose themselves to someone increases. They are able to have rewarding sexual relationships with other adult partners, but then they will have this desire or strong behavioral need to expose themselves to others that they are not in a relationship with. With exhibitionism, it is almost 100% a male perpetrator and a female victim. Fetishism. Fetishism is an individual who becomes sexually aroused from a non-living object. They intimately associate this inanimate object with the human body. Some examples of well-known fetishisms are a fetishism with shoes, gloves, or stockings. The object itself can be used either alone to incite sexual arousal and masturbation, or the object can be incorporated during actual sexual activity to heighten and produce excitation. Fetishism onset occurs in adolescence, and what is notable is that whatever the object is that they have associated with the human body, it is without that object that this individual is impotent or has an inability to become sexually aroused with just the human body. Frotteurism is sexual arousal from touching or rubbing up against a non-consenting person. This is almost 100% male. This individual will identify their victim, and it's always going to be in a crowded place. And then the fantasies will begin. They will fantasize that they have an actual relationship with this stranger. And then they'll put themselves in a position and then wait to be pushed against, or if that doesn't happen soon enough, they may reach out and just grab this non-consenting stranger. They usually will avoid arrest because the victim is so shocked and in such disbelief that they have just been groped in such a way in a public place that the individual usually gets away before the victim has, gathered themselves enough to make any identification. Or it can be something very subtle, like just rubbing one's genitals against an unsuspecting stranger on a crowded train or bus, so that by the time the victim realizes that was an inappropriate thing to have taken place, the individual has already moved on and disappeared into the crowd. Pedophilia, that's probably the one that we are most aware of or that we have heard of the most. Pedophilia is a sexual attraction to prepubescent children by adults. The molester or perpetrator has to be at least 16 years old and has to be at least 5 years older than their victim to be considered pedophilia. This is the most common form of paraphilias, is a pedophile. The onset usually occurs during adolescence and runs a chronic course, and this is especially with male pedophiles with an interest in young boys. Masochism, sexual masochism, is the recurrent urge or behavior of wanting to be humiliated, a desire to be dominated, to be beaten, bound, or otherwise made to suffer through real and not simulated acts of rage, such as rape and mutilation. Some sexual masochists do accidentally die during their sexual acts. The most common death from sexual masochism is choking. Sexual masochism is a chronic disorder. It can be seen throughout the lifespan. It doesn't tend to taper off after any certain age. This is one that I was referring to that might continue on into adulthood after the age of 50, but does tend to happen in isolation or with a cooperative partner. Sexual sadism, this is quite the opposite. The sexual sadists do tend to seek out the sexual masochists, because a sexual sadist derives pleasure and becomes sexually aroused from inflicting the pain and suffering, from causing the humiliation on either a consenting or a non-consenting person. The excitement for this individual occurs from the victim's response to the pain, such as their response to the repeated hitting or burning of the skin, rape, torture, and sometimes even the death. It is a chronic disorder as well, and it tends to display a pattern of severity with the acts that will increase over time. The individual will require more severe acts of pain and suffering and infliction of humiliation to become aroused. Now, if this is with a non-consenting person, it usually requires apprehension by law to stop this individual. They cannot stop on their own. So if rape and torture and killing is the result from this sexual sadism, they will continue in this pattern of behavior. It is chronic until they are stopped by some means. Voyeurism is sexual arousal through secretly watching others in intimate situations, such as people disrobing or being naked, or watching others, non-consenting partners having sex. The old community term for this would be a peeping Tom. This requires no actual physical contact to be made, but the individual will engage in masturbation either during their invasion of privacy on the unsuspecting person, or they will take the images back with them somewhere more private, and then they will engage in masturbation while they recall or relive or remember seeing whatever it was that sexually aroused them. So they may be masturbating during or after the actual act of voyeurism. The onset is usually before the age of 15, and it is also a chronic disorder. They are able to have rewarding sexual relationships with adult partners. And the reason you don't see many voyeurisms in treatment is because the people that they are watching are usually unaware that they are being watched. And this behavior, being chronic, does not stop unless they are caught accidentally.